seen. Generalized treatment for all shortness of breath, we use the mnemonic PROP. We want to try to put the patient into a position of comfort that will not be detrimental to their shortness of breath, right? So when we're talking about position of comfort, we really want to try to keep this patient sitting up, make sure that they're at a upright angle, sitting up, make sure that they're not tripoding, make sure that they are not laying flat, specifically if they are short of breath. We want to make sure that the patient's able to rest and rest accordingly. We don't want to get them too anxious. We want to provide them with oxygen, and the liter flow is based on you and the readings that you're getting based on what you guys are seeing as far as skin color and the actual oxygen device that you want to use. And then possibly remember that we might need to do positive pressure ventilation, which is assisting their ventilations with a CPAP or possibly a BVM. Okay guys, going back into oxygen therapy, remember that we are never going to withhold oxygen from any patient that needs it, okay? Even if you're getting good vital signs, right? Even if you have that patient at 94% or higher on their oxygen saturation, even if their end tidal is in between 35 and 45, okay? Even if their blood pressure is good, if their skin's warm, pink, and dry, and their mentation is spot on, if they're complaining of shortness of breath, we're still going to give them some sort of oxygen therapy, okay? Again, non-rebreather is really what we kind of go for at first. It's kind of our go-to. It's the most common way that we give oxygen therapy. There's a typo on this slide. Remember, it's 10 to 15 liters per minute, not 10 to 12. It's 10 to 15 liters per minute. And if we really don't think we need that much oxygen given to our patients, we can step down to the nasal cannula, which is 1 to 6 liters per minute, and then kind of gauge it from there. But start them off on the non-rebreather. If they're satting good and they're maintaining their sats, let's see if we could just drop down to the nasal cannula and see if we can give them some kind of relief with just the nasal cannula. If we need to, we're going to go straight to the bag masks with supplemental oxygen, specifically for patients that are breathing less than 8 times a minute. We definitely want to start thinking about maybe going straight to the BVM in order to get them to 12 to 20 breaths per minute. And if their rate is greater than 30, now there's a caveat to this. If their rate is greater than 30, we should really be trying to coach their breathing down first. Again, that's where you guys are going to get in their face. You're going to make eye contact and you're going to show them how to breathe, okay? See if that works first. Again, don't spend too much time on that, kind of trying to focus on getting their breathing rate down. If you can't get their breathing down within a couple minutes of actually attempting to coach their breathing, there may be a possibility that we need to go straight to the BVM and help them out. I would still attempt the non-rebreather first. I'd put the non-rebreather on them and then kind of coach the breathing with the non-rebreather on them. And then if that doesn't work, then yeah, we probably have to go straight to the BVM. And again, we need to try to synchronize this with the patients who do have spontaneous breathing. That is definitely easier said than done. That is a technique that's going to take quite a bit of experience at first in order for you guys to be able to perfect that. And you guys will get that once you guys get out into the field. They'll also get more supplemental training on that when you guys get into your respected services. But anyways, either way, we're doing it. You guys can see the 2-person bagging there. One person's actually holding the mask down. The other one's actually squeezing the bag. That is the preferred method. Again, we are going to train you guys on how to do it as just a 1-person bagging. But again, we're just looking for chest rise and fall, right? Just squeeze that bag enough in order to inflate their chest and then stop and give them some time to exhale. It should be 1 breath every 5 to 6 seconds when you guys are ventilating your patient. Make sure that you guys are doing the proper rate, and make sure that you guys are also starting to kind of have somebody feeling for the pulse. We want to make sure that that pulse is coming down with our breathing in order to make sure that we are truly doing effective bagging. Now, that's not always the case, right? We could be doing effective bagging, 1 breath every 5 to 6 seconds. just squeezing the bag enough until we see gentle chest rise, and the pulse rate is still not going down. At this point, this is when you guys would have to start thinking, hey, my patient more than likely is going to start to crash on me. I have to think about whipping out a advanced airway such as a King or an LMA. The big thing when we're dealing with somebody in respiratory distress is we don't want to stay on scene with them. Okay, guys? We want to make sure that we're either going to do an ALS-ILS intercept, right, depending on how far away we are from the hospital, or we're going to get them in the back of the ambulance and we're going to do everything en route to the hospital. Also give an early notification via radio report to the facility that you're going to for the emergency room to be prepared for the patient that's coming in. And again, when it comes to ALS intercept, if you guys are closer to the hospital, you guys will always be requesting ALS intercepts, period. But if you guys are closer to the hospital and you guys do need to up and leave, don't wait for ALS, okay? Don't even wait to intercept with them. Just take them straight to the hospital. If ALS is closer, then you might want to throw the patient in the back of the ambulance and rendezvous with ALS, but don't ever wait for ALS to actually get to your scene. Every intervention that you guys perform deserves a reassessment, okay? So every treatment that you guys give your patient, right, it deserves a reassessment. That means that once you guys assess your patient first, you guys put them on oxygen, we need to reassess to make sure that that oxygen is benefiting our patient. If we're going from a nasal cannula to a non-rebreather, we need to be reassessing our patient to see if it's working. If we're going from a non-rebreather to BVM, we need to reassess to see if it's working. And then if we need to go from BVM to an advanced airway, we still need to reassess, okay? This is true with any medical emergency, not just respiratory, right? If we're giving medications, right? If we're giving albuterol or an ipratropium or something like that, we want to make sure that the medication is doing what we are expected to do, or we want to see if the medication is actually hurting the patient. Either way, we want to make sure that we are reassessing our patient very often, all right? We kind of hold us to about a 15-minute period, okay? Every 15 minutes deserves a reassessment, okay? That is including even if your patient is 100% stable and you really haven't done any interventions for your patient. And you guys will have patients like that, right? Where there's nothing really wrong with the patient, but just because there's nothing really wrong with the patient doesn't mean that there should be no reassessments. Things can change very quickly. The dynamics of patients in the back of the ambulance can change rapidly. You can have patients that are perfectly fine, and next thing you know, they're crashing on you. We have to be able to pay attention to our patients. We have to make sure that we're reassessing our patients often. I know it says 15 minutes. I would bump that down to every 5 or 10 minutes, to be honest with you guys, specifically if we are dealing with a critical patient. The big take home is that if you are giving oxygen, it doesn't matter how much oxygen you are giving the patient. If we have problems with ventilation, if we have problems with the fact that we're not able to get that oxygen all the way down to the alveoli level in order for gas exchange to occur, if we have a problem with air moving in and out of the lungs and getting to the point where it's supposed to go, it doesn't matter. No matter how much oxygen you give the patient, if we can't get that oxygen down to the alveoli, we're doing nothing for our patients. And this is kind of a statement that I want you guys to kind of put in the back of your head. And this is really kind of there to prepare for the worst and hope for the best, and to keep in mind that there's always a possibility that you may have to provide positive pressure ventilation, either via the BVM or the CPAP to your patient. So make sure that you guys have that equipment kind of at least available to you within reach, just in case you have to whip that out pretty quick and stay on top of the patient's condition. Okay, now we're going to start getting into our actual disease processes, and we're going to start with asthma. Asthma is in the category of COPD. COPD is a broad term for numerous diseases within the respiratory tract, and it stands for chronic obstructive pulmonary diseases. Okay, asthma is a obstructive pulmonary disease. Okay, really, asthma is a immune response in patients that have asthma. It's usually caused by some kind of irritant. That irritant can be an allergen, or some kind of antigen that they might be allergic to, such as like a pet dander or just regular dust. It could be from cold air. We can have stress-induced asthma, and we can also have exertional asthma. We find a lot of exertional asthma in our children that usually outgrow it once they kind of get their lungs developed and whatnot. Sometimes the kids, their bodies grow a little faster than our respiratory tract does, and that's really what exertional asthma is. But remember that asthma is really, truly an immunological response, okay? It's kind of like I guess one of the ways you could put it is kind of like a focused allergic reaction that just kind of happens in the lungs. And when we do have somebody with asthma, basically it's we call it a hyperactive airway, and it's usually because of pathogen, and it causes widespread mucus production. Okay, so we start developing this kind of mucus production in our lungs, which our lungs don't like, and because of this mucus production, naturally the body's response is inflammation. So things start becoming inflamed. Specifically, your bronchi start to swell shut. Okay, they start to swell, and they actually start getting smaller and smaller and smaller, which means that we not necessarily have a problem getting air in. We have a problem getting air out. Okay, because our bronchi are swollen shut, we're actually air trapping in our lungs, and obviously that's bad, right? We can have some serious issues with asthma. Asthma attacks are a life-threatening injury. Fortunately enough for us, we do have many tools in our bags in order to help our asthmatic patients out. We'll talk about those here in a minute. So we call asthma a reactive airway disease, and that's exactly what it is. Our airway is reacting to something that our body does not like. It's an immunologic response, okay? It's basically a focused allergic reaction. So we could develop spasming, and specifically spasming of the bronchi or the trachea or the bronchioles, and it's all caused by some kind of outside stimulus. Again, it could be dust, it could be cold air, it could be stress-induced, it could be some kind of allergen that we're allergic to, like juniper or grass or something like that, or pet dander, whatever it is, okay? Based on the actual spasming of the bronchi, because the spasming of the bronchi and everything is kind of all happening at once, we start producing naturally mucus, and we're trying to do that to keep our airways, specifically our lungs, lubricated. However, our lungs are very good at producing mucus. They can actually overproduce mucus, and now we're starting to develop fluid in our lungs. And then we also do have the swelling or inflammation of the actual bronchi. And again, asthma is not a problem getting air in. Asthma is a problem with getting air out, okay? So that narrowed airways prevent effective exhalation, okay? That air becomes trapped, and then the oxygen exchange becomes diminished because we're not able to get the pressure gradients that we need and not able to do the diffusion properly from areas of higher concentration to lower concentration like we need in order to get adequate gas exchange at the alveoli level. This next slide is showing you some of the more common asthma triggers that we that we see in some of our patients. Excuse me, I didn't mean to cough in your ear. Pollen, dust, mold, animal dander, okay, such as allergens, certain irritants, smoking, secondhand smoke can definitely lead to asthma attacks. Chemical fumes, really strong perfumes or some kind of strong odors. It could be as sensitive to paint or even cooking, guys, okay? And then your everyday air pollution. Some can be emotional stress, cold air, certain types of medications, the sulfites in food, specifically in wines, can cause it, and also respiratory infections. You guys can actually develop a respiratory infection that can lead to kind of asthma symptoms, right? Some of you guys might have been at some point in your life, maybe been on albuterol medication or some kind of like respiratory steroid, like something called prednisone or methylprednisone or something like that while you're sick, right? It's just something to kind of keep the inflammation down in the bronchi in order to help you feel better and kind of get rid of the sickness for you, okay? Some people laughing too hard or even fits of crying can actually also lead to an asthma attack, but that also falls pretty much underneath some kind of like emotional stress trigger for our patients. Some classic signs and symptoms of asthma, specifically, the big one is an unproductive, persistent cough. This is famous in kids. Kids that are otherwise healthy, they just kind of have this persistent cough. I guarantee it is the start or probably full-blown, could be a full-blown asthma attack. Now, again, asthma comes in different layers. We have mild asthma, we have all the way up to severe asthma. It just kind of depends on the patient. Shortness of breath, also known as dyspnea. Usually we have some kind of increased respiratory rate, because when we are kind of suffering from asthma, remember, we're not able to expel any air, right? We're trapping that air into our lungs, so we're trapping that CO2 in our lungs. And once the body realizes, specifically the medulla and the pons, realize that our CO2 levels is going up, it's going to increase our respiratory rate, thus making the asthma attack even worse, okay? And again, that's just kind of the body's natural response to this. The body thinks it's doing good, but it's really hurting itself. Wheezing, okay? Wheezing is the big lung sound that you guys will hear in asthma attacks. And we're going to talk about wheezing specifically, I believe, yes, here in a little bit, okay? Wheezing can be inspiratory or expiratory, or it could be both inspiratory and expiratory. If it's both inspiratory and expiratory, it is considered severe. If it's just expiratory, it's a little bit moderate. If it's just inspiratory, that's usually the start of the asthma attack, okay? You could see cyanosis. We can have altered mental status, and we can have something called silent chest, which is basically we don't hear any breath sounds. Silent chest is extreme swelling of the bronchi, specifically extreme swelling of the lower airway. We treat that completely different. Basically, what we define as silent chest is if you guys cannot hear any lung sounds from the patient's nipple line down. Okay, so you're only hearing lung sounds in the upper lobes, and you can't hear anything from the nipple line down. We consider that to be silent chest, and we're going to talk about the treatment of that here pretty quick. So some good treatment or asthma management for us in the field. We want to make sure that they are getting good oxygenation and ventilation. More than likely, we're going to put them on a non-rebreather at 10 to 15 liters per minute. We can assist with an inhaler if appropriate. Make sure that you guys are looking over your pharmacology for epinephrine, albuterol, and ipratropium, okay? We definitely want to initiate transport quickly. We don't want to stay on scene with these folks, all right? We want to make sure that we're doing everything en route. Specifically, we want to give them some albuterol and ipratropium combined in a nebulizer and have them start breathing that in. You guys have a video of that on your lab shell. Make sure you guys are watching the skills video on that so you guys can see how that's done. If it is severe, okay, adults, anytime that we hear wheezing, we are going to give albuterol and ipratropium at the same time, okay? Albuterol is anywhere between, your adult dose is 2.5 to 5 milligrams over 5 to 15 minutes with a max dose of 10 milligrams, okay? You can deliver albuterol through a nebulizer, but you can also use the nebulizer with the BVM. You can use the nebulizer with the CPAP in order to help really try to get that medication all the way down, as far down as the lungs as we can get. The children's dose for albuterol is 2.5 milligrams, basically cut in half, so it's 1.25 to 2.5 milligrams with a max dose of 5. Okay, and you guys can repeat that every 5 to 15 minutes as needed. Okay, If you guys start off when you guys get on scene and your patient is already in silent chest, okay, so you can't hear any breath sounds from the nipple line down, we can go straight to epinephrine. Remember, epinephrine is a shot of adrenaline, and we're doing that in order to kind of hold back the immuno response that we're getting with the asthma attack. Okay, so remember that your epinephrine, your concentration is 1 to 1,000. You can give up to 0.3 milligrams, and hopefully we have an auto-injector or what's called a 0.3 ml syringe. So that's also known as a limited dosing syringe. Okay, if you have silent chest, that's going to be the first medication. You're going to give the epinephrine first, and that's a shot, right? So you're going to have to give it as an intramuscular shot, usually right in the deltoid. And immediately after you guys give the shot, go straight into your albuterol nebulizer mixed with ipratropium, okay? We talked about albuterol and ipratropium in pharmacology. Remember, albuterol dilates, helps to open up the bronchi, and that ipratropium holds the bronchi open for us. If we just gave the albuterol, eventually that swelling is going to come back, and it's going to be totally worthless on the albuterol we get. So we want to do it with the albuterol and ipratropium. And again, we don't give ipratropium to kiddos because kiddos do a very good job at responding to albuterol. Ipratropium is kind of overkill for our children, so we don't do it. But for adults, we want to do 5 milligrams of albuterol followed by 0.5 milligrams of ipratropium. You're going to mix both of those together into the nebulizer and have the patient start breathing in. When you guys are dealing with the patient on a nebulizer, you might have to coach their breathing. They need to try to take as deep a breath as they can possibly take, right? And hopefully those breaths are getting deeper and deeper and deeper as that albuterol and ipratropium are going all the way down to the base of their lungs and really kind of starting to open up the bronchioles again in order for them to release the air that has been trapped in their system, okay? If you have silent chest right off the bat, you're going to start with epinephrine, 0.3 milligrams as a shot. And let's say you guys are given albuterol and ipratropium and it's not working and it keeps getting worse and worse and worse. At that point, you guys would also give epinephrine after you've tried the albuterol and ipratropium, because we give epinephrine to patients that are refractory to the albuterol and ipratropium. Refractory just means that the albuterol and ipratropium are not working for our patients, so we want to at least get them started on the neb, hit them with the epinephrine, and then continue your treatment of the neb in order for them to open up. You guys do need to contact an MSEP before the administration of epinephrine, specifically if it is because you're giving the epinephrine after you have already given the albuterol and ipratropium. Make sure you guys are studying up on your guidelines on that for your pharmacology lecture.